take it away.
Thanks, Claire. I will just share my screen. I'm very pleased to be taking on essentially two nations today in terms of trying to address this question of antimicrobial use. I'm going to engage in work we've been doing in India and in Australia, which is quite ambitious for 12 minutes. So bear with me as I give you a series of teasers probably, and I'd definitely encourage questions in the chat to expand on this around why antimicrobial misuse continues to be a problem from a social and political perspective. So I'm going to cover some quite broad issues and systemic issues, and try and I guess give us a different way of viewing what is often constructed as an issue of behaviour, but I view as an issue of politics, economics, and priorities. So to give a brief overview, as instructed and requested, antibiotic use in Australia continues to be a major problem. We're guilty as anything of overusing antimicrobials, and the current data shows that things aren't really improving hugely. In fact, in many respects in healthcare facilities, when we're not necessarily getting worse in all contexts, but and a recent report, in fact, released yesterday showed that particularly in low socioeconomic contexts in Australia, antimicrobial misuse and levels of resistance are very high. So there's definitely a social structuring of the problem, as we always knew, and we have an enduring problem of inappropriate prescribing. And I want to speculate a little on how social and political perspectives might be able to shed light on why behavioural approaches are not necessarily working, which is probably the answer to question 3 posed to us today. I'm also going to cover our recent work in India. We've been working in India for over a decade now, more recently on antimicrobial resistance. Pre-pandemic, we managed to spend 2 months doing ethnographic work in India. Just sneak that in before the borders closed down. It's a pretty dire situation in many respects in the Indian context. There's a real need for social research on the multi-dimensional aspects of resistance. And as I've put up on the rather busy slide that you can see, resistance is a massive issue right from neonates to many other spheres of illness. It's actually embedded in structural issues around sanitation, water, and governance, as I'll talk about soon. Simply, it's not about rational or irrational use. It's a structural and systemic issue, which the audience and the other panelists will be well aware of. So I want to cover some of the ways that we might think about that across both these very different contexts, but which actually have some parallels in terms of the structural reasons why antimicrobial misuse continues, and in India actually is increasing from I guess a purely kind of surveillance perspective. So I want to jump fairly quickly to some of the data that we've collected very recently, both in Australia and India, and I'm going to start off with Australia. And it's an ARC, Australian Research Council study, where we took a very different approach to this issue. And we focused on those who govern as opposed to those who necessarily prescribe. So it's kind of the governance layer, if you like, and how it inflects behavioural practice at the bedside. This has not been something which is often taken into account adequately. And so we wanted to actually explore, well, how is practice embedded in how we govern, or how do we govern? And how might that enlighten us on why antimicrobial stewardship, for example, is not necessarily having as much uptake as we might, excuse me, like. So this particular study, which has involved 3 different health services already in Australia, 3 different hospitals, has focused in on issues of politics, performance targets, and issues of accountability, how we measure and how what we measure matters for antimicrobial misuse, but also stewardship, and also what the public expects and how people who govern often implicitly utilize understandings of what the public expect and how that filters down to whether they will or won't support initiatives to decrease antimicrobial misuse and resistance as well. And I want to just give you a quick overview of just a few of the interview excerpts from our ethnography and series of interviews in Australian hospitals to get the argument flowing, if you like, about why this might be continuing to be a problem in Australia. So you'll see here this hospital executive talking to us about antimicrobial stewardship. And the executive says it depends on where we're at the election cycle leading up to the election. It's all about KPIs and meeting patient throughput and not having any media attention around. So at any cost, we will make sure that we put patients through emergency and don't have waiting lists for elective surgery. Our focus will be on ambulances, not delayed at the emergency department, and that will be a success. Once the election's over, the focus is primarily on budget. So now it's about keeping our budget or meeting budget or not going over budget. So the focus will be entirely on how we're going to be more efficient and how we're going to achieve savings. And they government care less about whether or not we have ambulances sitting in the emergency department and whether we have surgery waiting lists. They care, but they care less. This happens on repeat on the election cycle. So this story that gets told, which might sound a bit like the broader politics of running a health service, but actually filters down to the extent to which antimicrobial stewardship or any of the things that we are trying to do might actually be successful. Another executive continues, so obviously from a budget point of view, there's a huge cost associated with us ultimately not managing resistant infections and patients appropriately, having to use more and more expensive drugs. But we don't directly measure anything around AMR. So it's not front and center of the conversation. It's not, I guess it's whether it's an immediate measurable good. Antimicrobial stewardship is due to the good it does at the time. That's where it feels like to me. I don't feel like there is something we could do that would significantly move the dial enough on the dollars for me to be able to measure it and say, actually, I've saved $1 million this year because we've done this. And I can actually see on my balance sheet at the end of the financial year, because it's generally hidden and rolled up in other medication costs, and our systems are not good enough to pick it up. So I can play around with things and we can spend a couple of $1 million on stewardship. I just need to know what I don't need to spend that money on now. So what this is describing is essentially an economy, which is based on short-term returns and budget items of particular value versus longer-term items that stewardship and reducing resistance might be considered. So this is speaking to the issue of legibility. And not just the legibility of resistance, the legibility of the cost effectiveness of reducing it. It simply isn't necessarily on those who govern and within their priorities. So I say, being the good social scientist, what about the broader public good or the long-term iterative crisis that we're entering into? Well, that moves into the nice space very quickly. And I said, can you explain the nice space? Oh, that you should be making the best endeavors and you should be doing stuff around this. But when push comes to shove, it's not one that we're actually going to hold you against. Even if you get to a KPI, it very quickly becomes one of those ones that sits at the bottom end of the page and no one talks about, unless you can get it to a priority point of view around the metrics, and then we actually worry about it more. So I guess this speaks to the issue of how key performance indicators and accreditation processes that we've got in Australian hospitals actually filter down informally to priorities within the health service. And it's pretty obvious from our conversations with the hospital executives that this is in fact not the case. And you can see it's obvious from the interview data. So you can see how this extends up to the level of politics. The Ministry of Health, they're interested in antimicrobial stewardship, will be minimising the extent to which it costs them money, maximising the extent to which it saves them money, and making sure they at least appear to be paying paper or lip service to what is required by appropriate concessive documents and statements. None of them in the high-level management in the hospital ever talks to me about stewardship. It's not something any of them are interested in. And that's probably because we have an AMS committee, don't we? We have our AMS rounds, we have our guidance system, and there's an attitude within the hospital that the problem has been ticked. And the box has a big tick sitting in it. And there lies the problem with why antimicrobial use continues to be misused in Australia, because ultimately it is not valued, prioritized, and costed within the system that we currently operate in. So we continue, and I probably will skip to focusing on India, although it seems like a crude kind of jump in this context. There's many other sort of narratives that I can share with those who are interested around the sort of will to make change in the short-termism endemic within the health services. But I think I will skip to the Indian context in order to abide by my 12-minute slot. The issue of antimicrobial use in India is on one level vastly different and on one level worryingly similar, in the sense that it's deeply embedded in economic structures and priorities. Practice follows governance, and the problem with often with low and middle income countries, to box them all into one category, is that we assume there isn't governance, or some people assume there isn't governance, or there's weak governance, or we need to strengthen it, when in fact things are already governed, often very effectively, by things that we don't really understand. And one of the things that we've been, or one of the arguments that we've been presenting around the issue of antimicrobial misuse in India is the fact that if you look at why practices continue, it's often embedded in a particular structural environment which emerged from a deregulation of the health services a few decades ago in India, and created a kind of two-tiered system where some of the healthcare institutions were governed by market principles, and others were governed by state or different levels of government funding and structures of accountability. So what we actually see in the Indian context is a highly diversified systems of forms of accountability, which really undo this whole argument about greater regulation or policies around stewardship and implementation of stewardship would actually be effective without considering context and economics and that environment. There are very clear issues around trust in the quality of drugs. There's been a push from the various governments in India around generics and to try and remove the pharmaceutical kind of influence over the prescription of antibiotics and the kickbacks that occur in that context. And those very elaborate and well-known systems often don't get accommodated in these kind of top-down approaches to let's try and tighten use and regulate use of antimicrobials in the Indian context. It doesn't actually make any sense on the ground. So just to briefly cover some of the accounts of public and private hospitals that we spent time in December and January 2019 and earlier this year, who talk in depth and in really interesting ways about how stewardship and any structures that we want to put in place around trying to address antimicrobial resistance and misuse have to actually acknowledge practices that are both diversified across institutions and will limit any attempts we make for behaviour change. So we've got a quote here from a female general physician, actually. Government sector people will come. So this is people coming to government hospitals, public hospitals, and then they're poor and middle class. And if we try and speak to them, they listen to us. For the wealthy in the private sector, they have this preset mindset. They'll come to doctors, and if we don't write antibiotics in the private sector, it'll be more difficult for a doctor to have any patients or retain their patients. So those kind of things will happen. They would already say, doctor, this is what happened to me. They are our clients. The private sector patients we treat as clients. And it's not very easy to disappoint your client. But in the government sector, nah, they do whatever the doctor says. So on one level, this looks like a behavioral issue, i.e. doctors not abiding by, I guess, strict or not abiding by best practice, or being what I would say pulled by the market, and or a series of markets in the Indian context. Actually, what we found is that the relatively limited funded government hospitals had implemented quite sophisticated stewardship programs because they didn't actually have the governing principles of kind of market, equity, profit-driven, I guess, ideologies, which actually meant that their whole contract with the patient was fundamentally different than what it was in the private sector. And often they would go from private to public and recognize that their prescribing would actually be different across those settings. And so that actually isn't an issue of weak governance. That is a question of actually what governs in different settings. And I don't think we often ask that question effectively enough. What actually governs what is happening here? And how might it be good, bad, or otherwise, as opposed to just creating a negative view of the market economy? So, and all these pictures in the background are pictures from what we took in the field work. And in fact, that's a stewardship round, and the results of that have been written on the picture in the background there. So in this, and I'll wind up the discussion to focus on the broader themes. The corporate hospitals here in Hyderabad, there's no antimicrobial stewardship which works in corporates. There's a single doctor, a single individual-based decisions. So one oncologist's decision about antibiotics will vary from the other oncologist's decision. It doesn't work as a protocol or unit-based protocol system. So most of the doctors in the corporate sector are quite used to working on their own and taking all of their decisions on their own. And I think this speaks to the issue of the kind of solidarity or a community versus the sole practitioner. And I guess that does speak to the issue of what the circulation of capital in a deregulated private system has implications for how we do stewardship, and what incentives that we would need to actually offer in that context, or disincentives, if you like, that might need to be a bit different from what we might in the public sector hospital. So I can send a detailed version of this analysis to anyone who's interested, and I think I'll wrap up with my summary points. And I guess, and I know it's a slightly kind of different way of approaching the issue of practice. Why does practice continue the way it does? But I think it's actually extremely important. It will come as no surprise to anyone here that I think that behavioralism will fail without a structural consciousness to how we approach the issue of AMR. And I think we actually need to bring in the power and sophistication of issues around political economy, elaborate and often informal systems of exchange, and we actually need to rethink regulation. And I think that means undoing and redoing. It doesn't mean actually just saying we need to better regulate or better count or better measure. It actually means we need to critically explore what we are making visible and how that feeds into the KPIs of the people who actually structure the delivery of health services and, in the end, shape practice.
Thank you so much, Alex. Fantastic. I'm going to go straight to Paula.
Okay. So can you see me and the slides?
Yeah.
Okay, excellent. So thanks so much, Alex. A lovely macro perspective, and now I'm going to plunge straight into a micro, but just to kind of connect the two dots.
The slide. Yeah, press on there. Let's just see.
Okay.
Yeah, perfect.
Yeah, just to connect the dots, when I was doing the field work in a hospital, in front of all the wards, there were these figures saying how many falls had occurred in this ward, etc., etc. And these were also all pasted in the screensavers of the clinicians. these metrics, and obviously none of these metrics had to do prescribing less antibiotics. So I'm going to talk today about something that is a kind of very specific problem, which is prescribing antibiotics for urinary tract infections for older adults in hospitals. And just to say, why is this a problem? So both old and new studies will tell you that about 30 to 40% of UTIs that are diagnosed in hospitals are considered inappropriate. And that is because older adults often have bacteria in their urine without any symptoms, and that's called asymptomatic bacteriuria. And according to guidelines, one shouldn't prescribe antibiotics for that. Rather, the diagnosis should be based on symptoms and signs and not on dipsticks. And here we can see a wonderful urinary dipstick or bacterial cultures. However, what happens is that clinicians keep diagnosing UTIs and giving antibiotics for older adults when they can identify bacteria in urine, especially in care homes, but also in hospitals. And our question was, why? And we take kind of three lenses to this problematic, sociologists as we are. And the first one is kind of, the fact that the current guidelines actually go squarely against modern conceptions of, what is good evidence in diagnosis and what is less good evidence in diagnosis. And this refers to sociology, history, and philosophy of medicine. So usually in classical modern medicine, results of diagnostic tests are considered most objective, the most kind of reliable, specific. They render the agent of disease visible. And in the case of UTIs, we obviously talk about dipsticks and cultures, which are the two things we shouldn't be using. The second most reliable form of evidence, especially in hospitals, is usually considered to be observable signs that the clinicians can see through their medical gaze. And in the case of UTIs, this refers to things like confusion, delirium, or the older adult being off their baseline, which again is quite vague. And in hospitals, usually what is seen as the least reliable evidence are patients' subjective experience of symptoms. So what they're sort of saying, this is what's wrong with me. And in the case of UTI, this actually refers to pain when urinating, because you need to ask a patient about that. And that is the most specific symptom. So that's kind of the best form of evidence, contradictorily. And this hierarchy is obviously compounded by the fact that we are talking about older adults. Then two other lenses that we took. One of them is that usually when we talk about antimicrobial resistance and antibiotics, we take quite a rational point of view. What are they doing? Why are they doing this? But we were kind of struck that there was this strange affective dimension going on in the way in which the clinicians and patients talked about their experiences. We identified two effective ways of, approaching diagnosis and prescribing, drawing on Arthur Frank's, classic work on illness narratives. First was kind of a chaos experience. Things were out of control, things were happening. People thought that they were not doing the right thing, but they were doing it anyway, and there was no closure. The second diametrically opposite affective experience was a kind of control narrative where, clinicians said, yeah, we're doing the right thing. This is what we're doing. And that's, obvious and evident. And oftentimes these narratives didn't quite describe the right way of diagnosis. So that was one lens. And if we kind of bring these two things together, we also observed that different staff groups and patients looked at both diagnoses and kind of had this affect in their experiences in slightly different or sometimes quite different ways. So junior doctors who usually diagnose were quite often overwhelmed, kind of felt somewhat out of control. They were also very focused on the diagnostic tests, but all the time doubting them, kind of, I'm not really sure this is right. Nurses, who play a crucial role in diagnosis, as Alex would tell us first, were very certain about what they were doing was the right thing. They used dipsticks and were focused on the signs. How did the older adult looks? And I just see that they're not looking right. And older adult patients that are typically seen to pressure for antibiotics, we didn't really see that. They were kind of like chaotic, and they didn't know what was going on. There were tablets and tests and so on being administered. They had their doubts and concerns, but they were not very clearly articulated. Obviously, we have this issue of how do these groups with very different experiences communicate with one another. And now, when I've given away my findings, I can tell you what these findings are based on. So basically, we did interviews with nurses, doctors, healthcare assistants, and patients and microbiologists, altogether 41, in 2 UK hospitals in the Midlands. And we conducted a thematic analysis, and we also did a narrative analysis to discern those affective experiences. Just to give you a bit of a taste of our material to illustrate our points. So this would be, perhaps quite typical experience of a junior doctor, although maybe a bit more intense than overall. And Anthony works in A&E, and he describes how they see UTIs very often. And the problem is that we don't always find something, and we just do it empirically, but we don't have any evidence or any proof or any cultures. We just treat it as a UTI, and it happens all the time, but we never actually properly diagnosed a UTI. And then I say, well, when does this happen? Well, in the acute medical unit. And these older adults, they come in and they're unwell and they can't tell you what's wrong with them, or they're too confused. Maybe I think maybe they have delirium, maybe it's a UTI. They don't know where they are. They can't explain what's going on. They sound like they have pain, or maybe not too sure. And just think about a UTI and then get all the investigations done. And we think about and hope it is the UTI. So here we can sort of clearly see that Anthony's focused on the diagnostic tests, the proof or the evidence or the cultures that kind of frustrate him because they don't quite provide conclusive evidence. And then these older adults, kind of seeing with the fairies, it's very difficult to understand what's going on. It's very chaotic. And he clearly thinks that he's not doing the right thing. He's hoping it's a UTI and maybe a UTI. But, he still prescribes even though he's not convinced about his own actions. And then we can see the experience of Elaine, a nurse, which has a very different air to it. This was typical of nurses, although not in all interviews. So she says, well, I think nurses are quite switched on to symptoms. So if you've got somebody who doesn't drink, their urine's more concentrated, or they complain of pain, we obviously encourage them to drink. Then we dip their urine. And if it's got some nitrates or leukocytes, we send a urine specimen. And if they're symptomatic, we escalate it. And really, we are quite good. So if somebody manifests with a bit of confusion, we will pick up those signs, and isn't that the most important thing? So this has a very different affective kind of feel to it. It's very controlled. We know what we're doing. We spot the signs. We do the dipstick, and everything is fine. And we're actually quite good at this. But obviously, it's not quite what we're supposed to be doing, according to some guidelines. And we also see a kind of more distance engagement with the diagnostic test, reference to nitrates and leukocytes, and very focused on the dipstick, because that's the tool that nurses have. And then an example of a patient narrative. This is a patient who had an operation in the hospital and had been diagnosed with a UTI twice. And I would just like to mention that when we did the interviews, out of the 14 patients, not one had only one diagnosis of UTIs, usually at least 2, sometimes half a dozen, oftentimes off and on all the time, etc. And so she tells, they must have given me antibiotics. Yes, it did. But the infection came back for some reason. And second time, the urine was cloudy because I didn't see it the first time because they tested it. But I certainly saw it the second time. And so I asked, did it hurt or did you have a temperature? No, not at all. And then I said, well, when did this second diagnosis happen? Was it with GP? Yes. And so I said, well, was it just done, kind of because they saw that you had had a UTI previously? Oh, yes, absolutely. And then they did the test again. And after taking antibiotics, it all cleared. So we can kind of see here that even though the doctors kind of thought that the old adult patients were kind of a bit with the fairies, the patients often made quite acute observations of what they were doing, like, they were looking at the urine, and I saw it too. They took this test, and then I didn't hurt, and that was curious, and I didn't have a temperature either. But then they gave me these antibiotics, and I guess it was okay. So, they were fine with the antibiotics, but they didn't exactly expect them, or it was just something that they noticed. Oftentimes they had other more significant illnesses that preoccupied them rather than this UTI. And so if we kind of, draw this into a close, health service research on overdiagnosis or UTI is often quite focused on knowledge deficit that clinicians don't know. They don't know the symptoms, or they don't know how to collect the urine correctly, etc., etc. And social science research has taken a slightly, more in-depth view and, noticed that clinicians overestimate the risk. Or like Esmita, who is soon going to speak, there's all these strange interactions going on between people that, doctors prescribe to make the family or the nurses happy. And there are different organizational cultures and roles. And there isn't anything in our findings that would go against this. Those are all corroborated. But, we also think that if we are actually going to sort of like, go against these quite ingrained practices, there's probably a need not only to tell people that they shouldn't treat bacteria, but to have some sort of a broader understanding of, what are these diagnostic tests picking up? What are these bacteria actually doing? Because, clinicians have this very strong idea that bugs are bad, and there are all these, posters on the walls, how horrible they are. And they talked about how they grow and exponentially, and they're soon going to take over the world. And aren't we familiar with that imaginary at the moment? But, how do you imagine, whether or not to treat the E. coli, to have a more kind of a contextual vision of when is it bad and when is it not bad, etc. So it's more like a story. We saw very few of those. We did see a couple. And then the other thing is that usually prescribing and diagnosis is seen as quite a rational thing to do. We know what we're doing. We have our reasons. But there is this kind of affect, and oftentimes the clinicians would do exactly the same thing, but some would have this sense of chaos and serious doubts, and some would be incredibly thinking that they know what they're doing. And I think that, if we kind of want to address that, definitely telling people isn't necessarily going to address it, but it needs some sort of a conversation or collaboration to pick up these kind of affective feelings. And then obviously there is this issue of miscommunication or translation that, people had very different views. And if we think about the clinicians that thought that the patients didn't really know, and the patients that kind of subtly made all these observations of what the clinicians were doing, we can clearly see that there isn't kind of a communication between the older adults and the clinicians. They don't quite speak from the same crib sheet. And what was also kind of a bit odd for a sociologist who hadn't worked in hospitals before was the fact that the nurses and doctors, even though they were the partners in crimes that worked, jointly, really kind of inhabited quite different universes. So the other ones were quite doubtful, and the other ones were very, certain. And the nurses were very wedded to the dipsticks, whereas the doctors considered them to be a bit below them, and they were more interested in the bacterial counts. So I guess as a social scientist, I would say that, there's quite a linear mode of communication or instructions going on, that focuses on kind of rational advice. And I'm not saying that doesn't necessarily work, but there is much less sort of like imagining what might be wrong with here. How could we think about these things differently, or how should we communicate together? And I'd like to also mention a little anecdote that after this study was conducted, the PI, who was a microbiologist, took all the dipsticks away from the acute medical unit and said, okay, problem solved. And after that, the nurses went into revolt, and they contacted the trust and got the dipsticks back. And of course, I would have been dying to know what happened next, but unfortunately we lost contact, so I don't know what the season 2 of this series is, but it's a kind of an example that it didn't really work, so a different approach would have been needed. And we published the thing on affect and communication. The bacteria is still in the works, and I didn't do this alone. So these are my collaborators and the funder and the sponsor who was kind enough to work together with us on this study.
Fantastic.
Thank
Thank
you.
you very much, Paula. I'm going to move straight to Justin. We're going to have a change of continent again. You need to unmute yourself.
Yep, great. Thanks very much. Right, so I'm going to try and share my screen. Hopefully it goes as well as it did in our little practice. Okay. Okay, sorry. Right, can everyone see my screen there?
Yep, just you need to play.
Yep, is that working now?
It's not playing yet.
Is that not there? It says that I've expanded the screen. Oh dear. Right, is that not working?
It's there now.
Ah, fantastic. Great. So thanks very much.
I have to wave at you when it's 12 minutes.
Yes, no problem. So firstly, thank you to Alex and Paula for their macro and micro analyses respectively. I'm going to take somewhat of a middle ground and try and sort of move between the two. So my talk's called Architectures of Antibiotic Use, Preliminary Findings from Malawian and Zimbabwean Health Facilities. So I'm a medical anthropologist at the London School of Hygiene and Tropical Medicine, and I'm speaking today on behalf of our FIEBRA social science team, which is a fantastic team working on antibiotic use in Malawi, Zimbabwe, and Myanmar. So that's just our team there. So today I'm going to talk about the parts of our work that have involved looking at prescribing practices in formal health settings, focusing on our two settings in particular in Africa, Malawi and Zimbabwe. So I'm just going to start by saying a little bit about how social scientists and particularly medical anthropologists have been framing and researching antibiotic prescribing in health facilities in Africa. So in sort of the 70s and 80s, medical anthropologists working in formal health settings were largely working in alignment with the, I suppose, the biomedical and public health problem of encouraging people to attend health facilities where they could get the care they needed. And where prescribing practices was analysed, it was tended to be with a view to improving rational drug use and guideline adherence. So at the time, there was not quite the critical lens on turned back on biomedicine that we see now. And there were quite sort of functionalist and cultural systems ideas influencing accounts of prescribing. So just a quick example here. The magic of prescription thus works in two ways. It restores the patient's confidence in recovery and the doctor's confidence in his own competence. So while critical medical anthropology gained momentum in the 80s and 90s, it still nonetheless remained rare for anthropologists to conduct, to actually enter the hallowed halls of biomedicine and conduct research in health facilities. And that sort of changed somewhat during the when global health emerged in the 90s and 2000s, when we had a much sort of greater scrutiny placed on biomedicine and science itself, and I think a greater proliferation of research conducted in formal healthcare facilities. And given the focus on mapping this new world of global health, the particular focuses of research were HIV, TB, and malaria, and mapping global health. And yet still few studies were conducted on antibiotic prescribing specifically, really until AMR emerged on the agenda. And the FIEBRA study, of which I'm a part, is part of that increasing interest in this domain. What we're learning as we sort of figure out this world is that to explain antibiotic overuse or irrational use, we have to look somewhat beyond the implementation gaps or resource constraints, which are of course problems, but also to look to the wider architectures of global health and specifically of antibiotic use that have contributed to the reduction of care in Africa to pharmaceuticals, and at the same time make it very easy to displace blame for acting irrationally onto prescribers, patients, and I suppose end users. And we've written a little bit about that in Medicine, Anthropology and Theory. So do feel free to look that one up. So here I'm going to talk about two of our settings in which we've been doing research, Zimbabwe and Malawi, and I'm going to describe briefly the patterns of use we've seen, and I'm going to suggest that these are best explained not in terms of local rationalities or ignorance, but rather in terms of what we might call global architectures of antibiotic use. So we conducted ethnographic fieldwork in public clinics and hospitals between 2020 and 2021. So both Malawi and Zimbabwe are settings in which I think quite sort of there's been widespread reports of widespread overuse of antibiotics and resistance to multiple antibiotics, which have been reported in country-level situation analyses, surveillance, and research studies. And often, sort of the blame, like as we know, tends to be placed on sort of on end users, and behavioural and knowledge-based interventions have been suggested quite predominantly. So our aim really, by conducting ethnographic fieldwork in public clinics and hospitals, was to identify patterns of prescribing, and given the focus of our study, particularly for febrile illness, to understand what care is in relation to antibiotics, and to capture reasons for prescribing beyond clinical guidelines. So we're conducting research in Chikwawa district in Malawi and Harare, the capital of Zimbabwe. So one is quite a rural region with very high malaria risk, and the other is an urban setting with low malaria risk. So they're quite diverse settings and quite useful for capturing sort of differences in prescribing patterns. So I'm going to skip straight to a graph which shows the antimicrobial medicines prescribed in two outpatient departments in Chikwawa district, one in a district hospital and the other in a slightly more remote clinic. And these figures include both prescriptions collected at the outpatient department pharmacy and from actually sitting in consultations. And the only thing I really want to draw attention to here is the fact that cotrimoxazole, an antibiotic, is by far and away the most commonly and widely used antibiotic, with antimalarial drug LAR, which is one of the ACTs, coming in a sort of close second place. And really, so I just wanted to explain, why exactly is cotrimoxazole quite so prominent in this setting. And I think the first thing to note about Chikwawa district is just the sheer resource, the extreme scarcity of the setting. Clinicians had very, very few options to provide care, with very little time to spend with patients, usually less than 1 minute, very few diagnostics, and almost no drugs. But it's not just resource scarcity at play here, but the provenance of cotrimoxazole itself is closely connected to the interplay between the malaria and HIV donor programs, which are hugely prominent in this area. So with the high incidence of malaria and the very aggressive public health messaging around fever being equivalent to malaria, and the fact that there's been a pervasive malaria discourse in Africa such that fever is almost equivalent to the diagnosis of malaria and antimalarials given as a result, at least until recently. So very much we found that the expected norm of care is antimalarial medicines, and I think that holds true for both sort of patients and providers, that's sort of the norm of care. But since 2010, when malaria RDTs came into were scaled up and introduced into treatment guidelines, antimalarials can't be distributed without a positive MRDT. And that's produced kind of great uncertainty in situations of negative results. And into this sort of gap, you could call it, this void of uncertainty, we have the HIV program, which, and cotrimoxazole is supplied by the HIV program as prophylaxis, but the fact that there are no other medicines on the shelves, this is what is prescribed for pretty much everything. So there's a nice picture on the right there that shows the ART program, the full shelves, compared to the essential medicine shelves next door on the left there. And that really is an interesting in the UK government's contribution to care in the region as being this container to keep drugs under lock and key. So that's just a little bit about why cotrimoxazole is so prominent. And just a couple of quotes here from interviews. We have only cotrimoxazole. That's all we have to give. We give it out all day because it is all we have. That's a health worker at one of the clinics. So because the antibiotic are always available, we just give them cotrimoxazole since it assists with various diseases. Maybe it would help him as well. We just tell them that if they should come again the following day, so that we should do a checkup on the child. Another health worker this time at the hospital. So just now to flash straight across quite crudely to Zimbabwe. So again, similar to Malawi in some ways, what we might call a normal emergency permeated sort of the everyday routines of the clinic, the places where we spend time, the clinics and hospital. So very much shortages of time, diagnostics, drugs, and regular persistent health system collapses made care almost impossible to provide sometimes. As well, very high rates of HIV in the country, 12.8% prevalence, which is actually higher in urban areas. And in Harare especially, a long recent history of cholera and typhoid outbreaks. So we found that a greater range of antibiotics were available and used than in Jikwawa district, but selection and use very much determined by availability and access to essential medicines very, very much in shortage. So the Zimbabwe National Treatment Guideline is something that we paid quite a lot of attention to in our research because it's quite a fascinating material artifact. So EDLIS is a legacy of the essential drug and rational drug movement in the 1970s and is quite a key part of Zimbabwe's particular success in bringing about rational drug use within the context of a strong primary care system. I think as older studies have found, and we also found, the treatment guideline is often referred to as a medical Bible of sorts. And another thing that's quite particular to Zimbabwe in many ways is that we found, and as many people will say have worked in this setting, the knowledge of antibiotic indications from among nurses especially is phenomenal. And quite a strong commitment to rational drug use, which is embedded in the guideline. But what we found is that nonetheless, antibiotics are routinely prescribed beyond treatment guidelines. So again, flashing towards just a graph here, which shows antibiotic prescription broken down by diagnosis from 741 consultations in 2 clinics. So the one on the left, the bar on the left is one clinic, and the bar on the right the other. And so want to just point out is that there are certain sort of key indications where, even though not indicated in the National Treatment Guideline, antibiotics were routinely prescribed for instance, mild acute respiratory infections, particularly, and for diarrheas. Even though they're not indicated as such. So why is this the case? Pardon?
2 minutes.
2 minutes. Okay, so EDLIS has so why this pattern of use? EDLIS has a strong emphasis on rational drug use, but at the same time, the guideline is actually built upon an essential medicines list, and so it's quite. We might say this contributes to the equivalence almost of medicines being care in this setting. We also found that EDLIS no longer inspires the faith that it used to. Perhaps the proliferation of global health programs, which introduce their own guidelines, and then these tend to start on the ground and retrospectively written into EDLIS. And so the guideline these days is always running behind, out of date, and often loses touch with the empirical reality that people are facing on the ground and the guidelines being used. And moreover, the idea that one can assume a self-limiting viral infection is challenged by the reality of reduced immunity brought about by HIV, malnutrition, and also the persistent outbreaks and expectations for medicinal care. And with the sort of systemic uncertainty compounded by the reality that care has been reduced to medicines, it's very, very challenging, we found, for health workers not to prescribe antibiotics. And indeed, the idea of sustaining this neat viral bacterial distinction, which we often find in guidelines, so as to prevent, for instance, amoxicillin being overused. One EDLIS developer said that this really, conceded this amounts to passing the buck of this wide systemic uncertainty onto the conscience of frontline prescribers. So I'm just going to skip these quotes and move straight to our conclusions. So the message I really want to put forward here is that clearly resource shortage is a formidable challenge, but the problem is not just an implementation gap or resource challenges, but a global architecture of antibiotic use that has created a systemic reliance on medicines to do care. And as Claire and our colleague Laurie have written about recently, is that antibiotics have become quick fixes for care, productivity and hygiene, and have come to prop up our ways of doing care. And thus, as Alex also mentioned there, that diagnostics and behaviour interventions and diagnostics are unlikely to bring about sustainable change unless this wider architecture is also addressed. So moving forward, we contend that there's a need to build a fuller picture of patients, dis-ease and care back into clinical guidelines and health systems, and to move back in the other direction from the fact that people in lower middle income settings tend to get case management rather than care at the moment. And we wonder what it would take to build back care into clinical guidelines and systems. And in the middle term, I mean, these are quite large tasks. And in the middle term, we've been thinking about what interventions might work that require both political will, but also go beyond targeting individual behaviour and might be feasible in the middle term. So one idea we've been exploring is safety netting, which is something that's used in UK settings and it's the idea of sort of a delayed prescription. And what can we do to support the clearly great knowledge that healthcare workers often have of antibiotics, and allowing them to explore the possibility of not prescribing antibiotics in certain situations, and actually allowing them to gauge for themselves what works and what doesn't. So that's just one intervention we're looking into at the moment. It may not be possible in a setting like Chihuahua, but in a slightly more stable setting like Harare, this is something that we think could actually hold some traction. So thank you very much. And there's our website and Twitter handle. Thank you very much.
Thank you, Justin. Fantastic. We will go straight to Esmita, who's ready to go.
Thank you very much, everyone. Hello. So I'm going to also time myself to make sure I don't go over. I hope this is working.
We can see it, but you think you need to start the screen share, the slideshow.
Okay, yeah. And I'm sorry about the background noise. It's out of my control. They're cutting the grass outside. This is the problems of living in central London in a small flat. But so I'm Esmita, and I'm going to be talking about antibiotics as care, status of use, and reasons for use, and some proposals for action. And I have a disclaimer at the beginning to make, in that I'm not a social scientist. I'm a clinical pharmacist by background, so it's a pleasure to be joining this panel of experts. And I'm continuing to learn about how we can use social science research to better understand antibiotic use in hospitals. And I just thought I'd remind ourselves about why we're looking at this dilemma in human populations, because still antibiotic use and misuse in human and animal populations remain two of the biggest contributing factors to AMR. And of course, as soon as antimicrobial resistance emerges in a strain of bacteria in one part of the world, very rapidly it is spread around the world, and we begin to see it causing problems in healthcare institutions and hospitals wherever we happen to be, which is why we are encouraging increasingly global partnerships and collaboration in tackling antimicrobial resistance from different angles and different lenses. And of course, in order to be able to do this properly, there have been many guidelines and policies from both international bodies such as the WHO and nationally within governments and departments of health to try and rationalize antibiotic use, developing guidelines and policies and national action plans. And the WHO have recently also helpfully put together a categorization of antibiotics by risk of antimicrobial resistance and risk of multi-drug resistance. And this is very helpful. The AWARE index, which classifies antibiotics as access, watch, or reserve, because it helps us to be able to have a universal means of measuring the quality of antibiotic use in different healthcare settings. So we've begun to try and do this in India, where we have excellent researchers on the ground who are supporting and working with us to try and see, in reality, what is the quality of antibiotic use in a given hospital, in a team of people, in one particular specialty. So this is a surgical specialty, acute surgery, in a private hospital, private charitable hospital in India that has initiated a public-private partnership initiative for antimicrobial stewardship across the state. And as you can see, the majority of antibiotics used remain in the watch and reserve category. And this could be anywhere in the world, really. In many parts of the world, we are still using antibiotics inappropriately in the hospital setting, despite evidence to suggest that we can use the first and second choice antibiotics that are safer to use with less implications for antimicrobial resistance. And we followed these patients up throughout their hospital stay to see what happens to the antibiotics they're on, whether they are de-escalated, so whether they go from red, amber to green, or whether they are stopped or changed from IV to oral. And we see that the majority of cases, actually, patients either remain on the therapy they are on or it is escalated. And the escalation does occur in about a third of patients to stop the antibiotics. Nevertheless, there is still a significant degree of inappropriate prescribing. And so to be able to understand this in the face of mounting evidence on rationalizing antibiotics, we have to understand the reasons for antibiotics and how they are used, and the cultural perceptions that people have formed around antibiotics as being the wonder drug. And part of it may be due to the time in history that they came about. It was during a World War when people were dying, and it was a beacon of hope for getting soldiers to stay alive. And they just this myth of the wonder drug, I think, has remained with antibiotics till this day. And we've conducted social science research, as has Professor Broom, who spoke earlier, and Professor Chandler, to look at how we can look at it from a social perspective and understand the multifactorial drivers for antibiotic use, both amongst the healthcare professionals, but also amongst patients and the public. And we've described the evidence of hierarchies and cultures that attribute different values to antibiotic use. This idea of prescribing etiquette, where prescribers are reluctant to question the behavior of their colleagues, even if they consider it to be inappropriate. And increasingly, speaking to different specialties, we have realized that a lot of non-specialist, non-ID infectious disease specialist physicians consider antibiotics to be a safety net for them. And they see it almost as an insurance policy, in that if they prescribe a good enough, as in a broad spectrum antibiotic in the orange and red category, by the wear index, they are saving time for their patients and they're preventing unintended consequences. So there are many complex interdependencies in how prescribers and the public view antibiotics, and really it makes antibiotic prescribing more a social act than just prescribing a medication. And of course, we then, as Professor Broom has already discussed, we have to look at the political and cultural and economic drivers for antibiotic use in different healthcare settings. This still remains to me a very powerful example of how antibiotics are viewed in different healthcare settings. This is a blog written by a doctor who at the time worked in South Sudan, and he describes the situation where inequality abounds and where children are dying of malnutrition. And in a setting like that, antibiotics are progress. And they represent inclusion in modernity in a place that is forgotten by the rest of the world. So in places like that, how easy is it to implement antimicrobial stewardship and lecture physicians about rationalizing their antibiotic use, or expect patients and parents not to want antibiotics for their children? So carrying on with Sudan, if we look at actually the disease burden in a country like Sudan, we see that the majority of diseases still are related to infections, so maternal, neonatal, lower respiratory tract infections, diarrhea, malaria, and chronic obstructive pulmonary disease. These are all conditions that will, rightly or wrongly, end up with antibiotic prescriptions. For example, for malaria, a study in Sudan found that 45% of patients who are admitted to hospital with malaria are inappropriately treated with antibiotics. So these are the complexities that different healthcare systems are dealing with. And in addition to that, we have to look at why antibiotics are being used and why are they effective in specific populations. And this was brought to the fore by this very controversial study published in New England Journal of Medicine that reported significant reductions in mortality in children between 1 month and 59 months by who had been administered azithromycin as a mass distribution of antibiotics. And that's a very difficult statistic to argue with, and it is about saving children from dying at a young age. So the Bill and Melinda Gates Foundation are looking at expanding this to other healthcare settings and other low and middle income countries. But what we should be asking is how are we going to address this ethical dilemma? And what is it that the antibiotic is treating? It's not always infections. It's lack of and lapses of care in other parts of the care system, including in maternal and neonatal care. So there is this ethical dilemma of diachronic justice with antibiotic use, in that the therapy we give today can have detrimental effects for future populations, and we owe this to future populations to use antibiotics judiciously. So what we're trying to do in different healthcare settings, and I've tried to put a timetable of the UK in the hospital where I work, we develop interventions that are evidence-based to try and influence the prescribing of physicians. And we do this through building capacity of the workforce, for example, having consultant pharmacists and infectious disease and microbiology expertise. We develop tools like apps that people can use to access policies, and we monitor. So the bedrock of antimicrobial stewardship is around having the structural process and outcome indicators in place to be able to implement change and optimize antibiotic prescribing behaviors. However, the issue is that often the structural indicators are very different in different settings. So if we take as an example the drug chart, which is what we would need in any setting to be able to assess the rationalization of the antibiotics being prescribed. The first picture is a ad hoc drug chart from a hospital in Uganda, where we are working with colleagues there. And this is because in Uganda, paper is very expensive and medication charts are very expensive. Not all hospitals can afford them. So physicians have to make do and create their own ad hoc drug charts. The second one is a drug chart in the hospital we work in India, where they've tried to create a separate antibiotic chart to highlight where it is in the medication notes. And the third is a much more sophisticated medication chart that was developed at the University of Cape Town Hospital, Groote Hospital, by our colleagues, to try and build in mechanisms and options for rationalizing antibiotic therapy. And this is the plastic dispenser is how many patients get their antibiotics going home. So the resources we are faced with are very different. And it's the same for the laboratory. This is the top two pictures are the green cupboard is the egg incubator that was used to eradicate smallpox, and it still works in Shisha Hospital in Dhaka, next to very high-tech equipment in the laboratory. And the bottom two photos are from University of Khartoum. So we are working across very different resources to have these expectations of optimized behavior. And we also have to really bear in mind to understand the context. So this is a picture of the hospital we work with in Kerala, in south of India, where taking off one's shoes is a sign of hygiene and cleanliness. So when people go into the ICU, everybody has to remove their shoes, and often people are walking around barefoot. And that's considered an infection prevention and control intervention in that setting. But in that setting, they have also been able to implement a really successful antimicrobial stewardship program. And this is the pharmacist there, Verinda, who's doing her PhD, looking at the role of pharmacists in antimicrobial stewardship. But they've also been able to implement structural process and outcome indicators to measure the effect of their antibiotic stewardship program over time. And the way they were able to do this is championing pharmacists to have a bigger role. And they also learned from the Nipah outbreak that they had. So this is the plan roadmap for the Nipah outbreak response in Kerala, where they worked with formal and informal networks and stakeholders, including central government coordination, but also with public participation to educate people about the spread of infection. And they then replicated this into learning for their antimicrobial stewardship program at a state level, and they were able to successfully implement through public and private initiative and involve both hospital and government institutions, both government and private hospital institutions into their stewardship program. But many challenges, of course, remain. So if we look at the barriers to global action for antimicrobial resistance, at the policy stage, I mean, Professor Broom has already covered this, but there are many barriers that we need to overcome, including access to data, public engagement. Funding is critical. So in the projects that we now are rolling out in South Africa and India, we are trying to work very closely with our local researchers to build capacity through partnership, through effective leadership, and to have contextual insights by doing social science research alongside the implementation research. And to make these efforts sustainable, we are training researchers within country to be able to take this forward. So concluding remarks, this is a very short time to be able to talk about everything, but I think it's really important to focus on the macro factors of accountability, including pharma. And the last picture, I will explain why I think pharma has a role to play as well, and regulation, that we need to shift attitudes around antibiotics and their status as wonder drugs. And for me, the question that, especially now in the age of COVID, I still struggle with is, why are people so reluctant to use vaccines but so eager to take antibiotics? And that's something that tells you about the different cultural values that people attribute to these things. And from the work and research we have done, I really believe that we are still treating antibiotics as a commodity. A lot of the non-specialist doctors we speak with think that somebody will discover a new antibiotic. So the problem is always somebody else's problem, and it's about short-term gains, which is what Professor Broom talked about. So I'm going to finish my talk by completely destroying my own reputation. This is a picture of me in India 10 years ago at an ID conference, and I was sitting next to an ID colleague of mine, and I'd left the UK with a terrible pneumonia, which was badly diagnosed in A&E. And if you've ever had a pneumonia, it's a terrible, terrible illness to have. And he said to me that I need to take antibiotics. So we walked across the restaurant to a grocery shop, and for 20 pence, I bought azithromycin and I treated myself, and I got better. And if I can do this, and if the system allows me to be able to do it, then it's very difficult to judge the behavior of others. And I think that's something what we need to focus on, that to make change, it has to be a collective effort and not just based on individuals. Thank you very much.
Thank you so much, Esmita. I will put up my share screen. Right, so we wanted to keep this to 1 hour and 15 minutes so that people would be able to escape and do whatever else they needed to do. What I'm going to do is, we have received quite a few, there we go. We've received quite a few comments from people. Oh, if I do this, I can't see my notes. Sorry, don't know how to do this and see my notes at the same time. So we will have to just see that sitting there. So we had quite a few comments coming through from people. What you can do instead is see us as the panel. That's better. And I'm just going to summarize them, and also just give a few kind of comments on points of convergence that I think that we've heard from across our panelists. So first of all, thank you so much. This was it was a roller coaster. That's what it was. Thank you so much for managing to keep to what is an enormous topic in a short time. Some of the things that I think really cohered across these presentations, what we heard repeatedly: getting beyond individual behaviour, getting beyond knowledge, information, simple information, simple guidelines. That this is not a story of demand. Nobody talked about this being a story of demand or ignorance. It's a story of affect, a story of care, a story of resources, structures we heard in everybody's presentations, around structures of organizations, resource distributions, economic and political arrangements, and governance. We also heard about how antibiotics and their use are situated in cultures of knowledge, and bacteria as well, and how they're really positioned in this way. And we're going to come back to some of those topics in the session that we'll be running the panel in December. And we really hear this issue of scale, how these uncertainties, this chaos or control on this micro level are really echoing and echoed back from some of these more macro level issues, and the interests that are involved. So questions that have arisen, and I've gone through and kind of pulled out some of the things people have said in the comments. But the first question I would ask that we can take away: should we work with or work around these structures? These are, these structures that we're describing are phenomenally challenging. So should we work with or around them? Then should we be making AMR a big thing in order to compete with all the other big things? Or should we be thinking about AMR smart policies that folds AMR in together with other things? What sorts of regulation might be required for different types of settings? Should that be tailored for the public hospitals versus private hospitals? How does this relate to medical professions? We had a question from Beth about what can the role of alternative forms of care and knowledge play. Colin has made the point about in people's own conceptions of pathogens, and AMR, the way that people's own conceptions of pathogens and AMR is really important, and there might be that might be worth exploring further. So hopefully Paula has spotted that comment in the window. Paula has suggested an interest in safety netting, but how could that be possible? And Justin has replied to that. And we'll also very quickly see that we have a few other, all of these will be stored and will be available on the recording. The question of public acceptability, I loved that question as well as Mita. That's just so fascinating. So the question of public acceptability of vaccines versus antibiotics. We also, Mashid says, study shows that 8% infected. Yeah, the social research on this connection between COVID and AMR clearly opens. I did read an article about the COVIDization of the research agenda, and that is clearly a thing. But yeah, is important. So what I'm going to do, we haven't managed to roundtable it because we have to close the session. So what we're going to do, only Colin's comments are visible to normal attendees. So we're supposed to put the, okay, I'll send them all to you afterwards because you all signed up. So I'm going to send you a list of all the comments that were raised. What we'd like to do is, this is, as you know, is part of trying to create a report. We'd be really interested in everybody else's comments on that. Anybody who contributes to it would be kind of acknowledged or co-authored. So we will continue this conversation. What I will do is just let you know about our next one. Share screen. Here it comes. So the next panel is here. The next panel is in October, and that is the pharmaceuticals and markets. And the next one and we are so lucky with all of these. Look at these amazing speakers we're going to have at all of these panels. So I hope you will join us for the next one. I will send around some further comments and some of the questions. I'm so sorry we didn't get to actually do the discussion. Next time we will either take more time and we'll do it for an hour and a half. I will have to poll some people and see whether we could stretch to an hour and a half. But thank you again so much to our panelists for providing such important insights. I hope we can do justice to it by taking it all forward. And at our event in February, we will be trying to convince a wider audience of the importance of taking seriously the findings that you've all been putting together from social research. So if everybody can do their round of applause emoji, that would be very nice. I don't know how you do that. Give it a go. People are raising their hands instead. Sorry. Everybody's raising their hands. Congratulations. Thank you very much. And we'll see everybody again in October.
Thanks.
Thanks very much. Thanks for inviting.